Welcome to the 1pm show. Today we've got a new guest presenter. Do you want to introduce yourself?
Hello everybody, this is Josh, back again and in the driving seat today, which is quite nice.
Yeah.
And we've got two other guests joining us today. Do you want to say hello, guys?
So I'm Jay. It's my second episode. Quite excited to be here.
And I'm Yin, MD3. Nice to be here.
Beautiful. And the topic of today is sepsis. So to kick things off, I thought we'd just start by going over the definitions of sepsis, or septicemia. So does anyone want to have a go at defining sepsis?
Is it a life-threatening reaction to bacterial infection?
Close, yes. So...
I've got one.
Oh yeah, go on.
Bugs
Jason.
in blood.
Bugs and blood.
Making your body not good.
Great, fantastic. That was a nice try.
Yeah.
But there's actually just recently been a new definition of sepsis that has been defined in some guidelines called the Sepsis 3 guidelines. And that definition is that sepsis is a life-threatening condition characterized by signs and symptoms of organ dysfunction caused by a dysregulated immune response to infection. So throwing it back to you, Jason, does that necessarily mean we have bugs in blood, do you think?
Well, I guess not now. I thought it
Yes,
was,
yes.
yeah.
So that's a good distinction to make, is the difference between sepsis and bacteremia. And that's something that when I kind of think back on my revision, something that I can get confused about. So,
just to clarify, you can have sepsis without bacteria in your blood.
Exactly. Yep.
Okay.
So bacteremia is simply just the state where there's bacteria in the bloodstream. So patients with bacteremia aren't necessarily septic, and patients who are septic don't necessarily have bacteria in their bloodstream. So I thought it might be interesting just to think about, if bacteria in the bloodstream isn't the only cause of sepsis, what do you guys think some other causes might be?
Hypovolemia.
So other sites of infection.
Like an abscess somewhere?
Sure. Yep.
UTI?
Sure. Yep. So UTI, and you're thinking like organs that are highly perfused, because the issue with sepsis, which we'll come to, is that it's not necessarily bacteria in the bloodstream, but it's a high level of circulating immune molecules, right? That causes the disease, and sepsis causes the condition.
Pneumonia?
Absolutely. Good on you. Pneumonia is actually the most common cause of sepsis, which makes sense when you think about it, because it's a really vascular organ. Like 100% of your blood will at some point pass through the lungs.
Okay. So it's more about the inflammatory molecules which are traveling around the body.
Exactly. Not necessarily the bacteria, but the inflammatory molecules that react to the bacteria. So pneumonia is one. We've talked about abscess. We've talked about urinary tract infections. So ordinarily we'd think more pyelonephritis, because that's higher up, and that's usually a more severe infection. Bacteremia is a cause.
Would you still say bacteremia is the most common cause of sepsis?
So interestingly, in this one study that I was looking at, pneumonia without bacteremia is more common, I believe.
Okay.
Because like you said, it's not necessarily the bacteria in the blood causing the problem. It's the circulation of these immune molecules around the bloodstream. So you can have these immune molecules leak out into the bloodstream and cause havoc everywhere without the bacteria necessarily disseminating as well.
So yeah, okay, that makes sense. So you could have a negative blood culture.
Exactly,
and still
yeah.
sepsis.
And you could still be septic.
It makes a lot more sense now. I didn't realize that.
Yeah, crazy.
Shit, man, I really I should have known this.
So just going back over, so the 5 most common sources of infection and sepsis are pulmonary, so pneumonia, intra-abdominal sources, so there'd be things like diverticulitis, cholecystitis, cholangitis, blood, so bacteremia, skin, cellulitis and abscesses, and urinary, like you properly mentioned, like pyelonephritis. So considering that sepsis really starts with infection, let's try and think about what risk factors there might be for sepsis.
Can we go for the big one here? Immunocompromised.
Absolutely. That's a great one.
Oh,
Anything else?
I was going to say an MD2 attempting a cannula.
Yes, 100%. 100%. Story of my life.
Yeah.
So, you're right. Improper cannulation. That's a breaking the
Yeah.
skin barrier. But what else
Make
might?
sure you do your online modules for that, hey?
Absolutely. And not just the click, click, click,
Yeah.
click. Next.
Yeah, you better take the full 45 minutes.
Yeah.
Yeah. Could you say the opposite with things like SLE and
Yep.
autoimmune conditions?
Sure. Because often when you have those autoimmune conditions, what are you given?
Yeah. Steroids.
Steroids. So
Yeah.
long-term steroid use, that's a risk factor.
Like with any risk factor, old age.
Old age, absolutely. But not just old age. We were just talking about this.
Kids.
Yes, that's right.
You guys
So interestingly, from my time in peds, something that I remember very fondly is we had... Sorry.
It's just a bit sus.
Something I remember very clearly from my time in pediatrics was we had a febrile 9-month-year-old, and my registrar asked me, Josh, like, what are your top 3 differentials? I don't know. I said something like pneumonia, appendicitis, gastro, or something, and he's like, nah, mate. Your top 3 differentials are sepsis, and sepsis for any febrile.
But that's just one difference.
Yeah, well, I remember it now, don't I?
Did hospital stays, would that be a risk factor? Like intubation, ventilation sort of thing?
Surely, yeah, because that's like an invasive foreign body that can be a site for infection, right? So I'm a massive fan of acronyms.
Massive. Oh.
A massive, huge fan. And here at 1PM, we like to keep things quite basic. So I've actually got an acronym for the risk factors of sepsis, and that is BASIC. So B stands for burns and birth, because instrumentation and retained products that can increase your likelihood of developing infection.
Yeah, makes sense.
A stands for age, less than 2, over 65. S for surgery. I for immunosuppression, whether that be by drugs or chemotherapy or radiotherapy. Also for intravenous drug use. And finally, C for chronic illness. So what kind of chronic illnesses do you think might predispose someone to infection?
Liver failure, renal failure.
Absolutely. Yep, all your failures pretty much.
Yeah.
So yeah, well done, guys. I just briefly wanted to touch on the pathophysiology of sepsis and go over disgustingly the immunology associated with sepsis, because it actually really helps when you start to think about the clinical features. We're going to focus mainly on the innate immune system. So cast your mind back, I don't know, the 3-4 years. So obviously the first step when it comes to the pathophysiology of sepsis is infection. So the host is infected by a pathogen. Second step is the pathogen is recognized by sensory white blood cells. That can be things like macrophages, neutrophils, mast cells, dendritic cells. And the third step is that these sensory white blood cells are activated. Can anyone remember anything about what they might do when they're activated?
So innate, right? So
Yes.
when they activate it, they release, I don't know which chemicals are cytokines.
Absolutely.
But they would
Yep.
like make the blood vessels leaking.
Exactly
so they can
right.
get to from the blood vessel to the sites.
That's exactly right.
Okay.
Perfect.
Yeah.
So
Cytokine storm.
that's read my mind.
Yeah.
So the first thing they do, as Ian rightly said, is they call for help and they release cytokines, and that recruits more white blood cells. But then they've got all these white blood cells coming in, can't get from the blood and into the tissues. So they increase tissue accessibility. Does anyone remember what that molecule is that causes vasodilation and increased tissue permeability?
Is it produced by an inflammasome?
The molecule?
Yeah.
Is it prostaglandin?
It rhymes with nitrous oxide.
Nitrous oxide.
Yes, boom.
Yeah. Wow.
Well done, nitrous oxide.
Yeah.
So far we've said cytokine release, nitrous oxide release, which causes increased tissue permeability and vasodilation. And the third thing that these activated sensory white blood cells will do is they'll begin a crude antimicrobial response. So before we recruit the adaptive immune system, where we get the CD4 and B cell and all that stuff, which I don't know about, these white blood cells release things like reactive oxygen species and enzymes that will damage the microorganism, but can also have off-target effects at the local tissues. So the fourth step after infection, recognition, activation, the fourth step in the sepsis, and what really makes sepsis happen, is a progression from a local to a systemic immune response, where those three things that we just mentioned happen on a systemic level.
So when you mean systemic, is it like all over the
Yeah,
body is what you mean?
Exactly. So, for example, if you have systemic release of these cytokines, you're going to have systemic recruitment of white blood cells, which are then going to release more cytokines, which then generate that positive feedback loop. So
would you say it's an inappropriate response to the infection?
It's hard to say that it's inappropriate, right? Because it is an appropriate response to an infection, because that's what you want.
Yeah.
You want these things to happen, but it's almost like an overreaction, I suppose. So let's say you have a systemic release of nitrous oxide, where at a local level it causes vasodilation and increased permeability. What effect might that have on a systemic level, do you think?
Hypovolemia.
Because the fluid goes from inside the blood vessels to outside.
Exactly.
Yeah.
Widespread edema. That's really
Widespread edema, baby.
That's really the driving pathological process. There are a few other things that happen, but it's that widespread edema that. Can you think of anywhere in particular that you wouldn't want edema to happen?
In your lungs.
Exactly right. Because if you have pulmonary edema, that can lead to...
Reduce the ventilation.
Exactly right. Resulting in hypoxemia.
Yep.
And it's this hypoxemia that then causes hypoxia at your end organs, and that causes end organ dysfunction.
Yeah.
Right?
Is that why your tissues die in sepsis? Because of this?
Exactly.
Oh, I thought it was the total body, like vasodilation, causes a drop in blood pressure.
That's a second part. So the vasodilation causes a drop in blood pressure.
Yeah.
So both of those two things, the drop in blood pressure, reduced cardiac output.
But quickly, what's the difference between hypoxia and hypoxemia? Because all the internal med consultants love asking.
Yeah, so hypoxemia is when there's not enough oxygen in the blood, and hypoxia is when there's not enough oxygen in the tissue.
Mm-hmm. That's right. And commonly hypoxemia will lead to hypoxia. Just to recap, when you get this systemic release of nitric oxide, what are the two things that happen?
Vasodilation.
So what does the vasodilation cause?
Well, reduce intravascular blood volume.
Which leads to what?
Which leads to hypovolemia.
Yeah, and
so,
at the lungs?
Reducing tissue perfusion. And the other one, and pulmonary edema.
Right.
And then what does pulmonary edema lead to?
Hypoxemia and then hypoxia.
Yeah, exactly. I love
And
that. That's a nice flowchart.
The first principles are coming out.
Yeah.
Yes, big time. And for bonus points, if your tissues are hypoxic and they no longer have oxygen to use for metabolism, what are they going to do?
Yeah, so whoever answered these questions gets to actually appear on another episode.
Anaerobic metabolism.
Okay.
You're a
Good.
bit keen there, jeez.
Follow-up question. This is for the gold medal.
Okay.
What are they then going to produce as a byproduct?
Lactate.
Lactate.
Oh, man, trying to get this. Jeez.
That's right.
That's rude.
Which is really important to think about, because as we'll discuss later, measuring a patient's lactate is one of the most important things you can do when investigating them for sepsis.
What does lactate do to the blood, Nian?
decrease pH,
Yeah. Which is,
metabolic acidosis.
yeah.
Absolutely.
Nice.
Really well done. So yeah, the last thing we're going to talk about, which only happens in about 35% of patients, so we'll just go over it really quick.
Okay.
So remember when we talked about like the three things that the white cells do? They call for help, release nitrous oxide. They also release these noxious chemicals. When that happens on a systemic level, it causes damage to the endothelial layer of blood vessels. Does anyone have a guess at what that would then do, or what that would then activate?
The coagulation cascade.
Very well done. Exactly. You get system-wide activation of the extrinsic clotting cascade, which causes coagulation or clotting, right?
Yeah.
Everywhere inside your blood vessels,
Not good.
like disseminated,
Bad.
Real bad.
intravascular.
Okay. You don't need to hype it up
Coagulate.
anymore, man. We get it.
And that leads to disseminated intravascular coagulation, like the condition, right?
Okay, cool.
Good old DIC.
So then, once you have all these blood clots forming, your fibrinolytic pathways activate because you're like, no, this is bad. We don't want these. This is cutting off all,
Too much coag.
too much coagulation. It's causing thrombus in all these small blood vessels and causing ischemia elsewhere. Very bad. So then they activate the fibrinolytic pathway. And when both of these things are going on, you get this weird paradoxical state where you have clots forming, but because you have these fibrinolytic pathways getting activated everywhere, you have a deficiency in your clotting factors and your platelets. So you can have clots forming, but you can also have hemorrhage.
Interesting.
Just remember, that doesn't happen in every single patient.
35%.
35%.
Not
yeah,
33.
that's right.
35.
Not 36.
35%.
All right. So from that, let's start to think about how septic patients might present. So we said the first thing that has to happen is there has to be an infection. What are some clinical features of infection?
Febrile.
Boom.
Low blood pressure.
Good.
Confusion.
Absolutely.
Tachycardic.
Sure. Yep. That's good. And it really kind of depends. So there are these general kind of features, tachycardic, febrile. They could have rigors, they could have night sweats. But then beyond that, it kind of depends on what system might be involved. So let's say the respiratory system is involved.
Accessory muscle use.
Accessory muscle use.
It's just going on my idea now.
Signs of respiratory distress.
Yes.
You could also
Come on,
have
you guys
tug.
tracheal tug.
Tracheal
yeah.
tug.
added sounds, breath sounds, stridor, wheeze, that kind of stuff.
Abdominal breathing.
Oh my god.
Nasal flaring.
Nasal
Nasal
flaring.
flaring.
Exactly
Tripoding,
right.
head
Oh my
bobbing.
goodness gracious, you guys are just too
Wheeze.
much.
Wheeze.
All right, and let's say you had an infection of your brain, of your meninges. What else might you present with?
Out of mental status.
Yep.
Yep. Confusion.
Exactly.
Non-blanching purpuric rash.
Yep.
Headache.
Exactly right. Good. You guys are killing it. Let's say you had like a genitourinary infection. What might you have?
Suprapubic tenderness.
Boom.
Reduce urine output.
Exactly.
Dysuria.
Dysuria. See, you guys are getting it. But that's almost what makes it difficult, is that because you can have an infection in all these different systems, the breadth of things that a patient can present with there's a lot of different things. So for that reason, it makes it kind of hard to pinpoint specific clinical features, right?
Yeah.
Okay. The next pathological process, hypotension. If someone's hypotensive, how would their heart respond? I should say?
Tachycardic.
Exactly. Moving on. Widespread edema.
Look a bit swollen.
Classically, with septic patients, they're described as flushed and mottled with warm peripheries.
Oh, mottled. They love
Yeah,
it.
boom.
Yeah.
All this fluid from the blood vessels are leaking into their skin and warming it up. And if they've already got a fever, it's going to be warm. And if they've got pulmonary edema, what kind of examination findings might you expect?
Correct.
With that, so you have end organ dysfunction as well. So then you're going to have all the signs and symptoms associated with your failures, your heart failures, your kidney failures, your respiratory failure, your liver failure, all the failures. I guess brain failure isn't a thing, but like you'll have altered mental status and like decreased GCS, right?
That is brain failure.
Yeah, I have brain failure often. So we've just touched on so many different things and so many different ways a septic patient might present. So I thought it might just be useful to categorize maybe the top 5 presentations that they might have. So does anyone have a stab at what's one of the most important things that all these patients are probably going to have?
A low blood pressure.
Do you want to define hypotension for me?
Is it below 90 systolic?
Yep.
And is it 50 or 40 diastolic? 60?
Yep, 60
Okay.
diastolic, great. And also a mean arterial pressure below 65, but who really cares about that? So yep, hypotension. Something else?
Tachypnea.
Tachypnea, yes. And that is the most common sign. In this, one of the things I was reading, it said that 99% of septic patients will have
Yeah,
tachypnea.
CJ, I go for the high yield ones.
Cool. And do you want to define tachypnea for me?
Depends on patient demographics.
In the adult,
Re-
in the adult
Rest rate
population.
greater than or equal to 30. I don't know. 25, 30?
You got the high yield stuff wrong.
Okay.
I had 22, but
22.
that's
okay,
all right.
fair
Shoot for the
enough.
moon.
Confusion.
Confusion, yep, that's also in mine. And that's useful. We'll come back to that in just a second because that's useful for one of the scores that you might use for a septic patient.
Is
But
lactate level one of them?
absolutely. That is the most important investigation you can possibly do, maybe behind a blood culture. But I read that an elevated lactate is one of the earliest signs or indicators that a patient's going into sepsis. And finally, and maybe the most obvious thing that a person with infection will have,
Fever.
And do you want to define fever?
Above 38.
Love it. Jason, do you want to just go over those 5 things we just said?
Okay, so the 5 key signs for sepsis are hypotension,
Yep.
tachypnea,
Yep.
confusion,
Yep.
raised lactate,
Good. Yep.
and fever.
Very well done.
Yeah.
Very nice.
Is there a specific lactate level we're worried about?
Yes, there is. Above 2 millimoles per litre is classically the threshold, I suppose. All right, moving on. Something that I've come across in my reading. You guys might have heard of it too.
Yeah, you're doing a lot of reading, hey?
I did a lot of reading. I read often. Does anyone know a tool which might be used for septic patients?
I can see it, but is it QSOFA?
It's the QSOFA tool. That's right. And something that I long misunderstood was that I thought that QSOFA was a diagnostic tool, and the 3 criteria in this QSOFA score, that being hypotension, altered mental state, and tachypnea, I thought, that's so convenient, 3 things, diagnosis of sepsis. But no, it's not what it is. It's a prognostic tool. That you can use the QSOFA tool to identify patients who are more likely to suffer poorer outcomes as a result of sepsis.
Interesting.
And they are the HAT criteria: hypertension, altered mental state, and tachypnea.
So, yeah, you don't want to be getting 3 out of 3 for that.
You do not want to be getting 3 out of 3.
Not good.
Funnily enough, actually, bit of an aside, Q stands for quick SOFA score.
I always wondered what the Q
Yeah,
stands for.
right. So there is an extended SOFA score, and our ID consultant the other day asked the one question she asked Jerry was, Jerry, what's the SOFA score? And he was like, it's hypertension, old mental status, tachypnea. And she's like, yeah, I want the SOFA score, and it's like 12 items long or something. This takes us on to one of our first principles, that being that no organ system is protected from the consequences of sepsis. So like we were discussing earlier, any organ system can be affected, and that means it can present in a lot of different ways. So when it comes to our investigations, we want to investigate widely. So starting off with bedside investigations, there is an infection going on. What kind of investigations do we want to consider?
Don't say MD calc, mate. Just
General obs.
General obs, yep. Underrated general obs. We'll take
That's
general
more
obs.
big exam, not investigation. Just saying. I'd say
Still high yield.
vitals.
Vitals, yep.
Vital.
I'm taking it.
Just like the fancy way of saying obs.
Yeah, it is. Hey, mate, once you start that OSCE prep, they burn into your mind, these bedside tests. Okay, vitals, in the end.
ECG?
Good.
Nice.
Let's keep it going around the table.
Urinalysis or urine MCNS?
Oh, 2 for the price of
Mate,
1.
Urine MCS bedside must be nice.
Just get
eh?
the urine
Yep.
from the
Yep.
them. and-
That's where it comes from. I consider it bedside.
You get it on
Back
the
in my
bedside.
day,
You get it at the
Oh.
bedside.
On, switch on, Jason.
Fuck, I'm done.
Can anyone else
Um,
think of another one?
Lumbar puncture.
Yes. We're just
What?
talking. We're just talking about.
What fucking bedside investigation are you?
Yeah, big time.
Okay,
You
blood
get it
test.
from the
MRI
bedside.
next to the bedside. I know it may literally be in the next room. It doesn't
No, no,
mean
no,
that you
no,
call
but-
it a bedside.
But you do the
investigation.
LP at the bedside though.
Don't say
I
you do
consider
it-
it bedside, and I'm the master. So sit down, Jason. You're not in charge this week.
So you're in a old country town. This patient comes in with possible sepsis.
mean,
you're going to do a lumbar
If you're
puncture at
comfortable
the
enough,
GP.
go for it.
Respect. I would. That's ballsy. The last thing you might do at the bedside is collect a microbiological sample,
Yeah.
Bedside test.
such as
Skin swabs, any wound swabs.
exactly perfect sputum,
Yeah.
stool sample, joint aspirate.
Yeah. Not freaking lumbar puncture. Jesus Christ.
That is
Lumbar
a micro-
puncture counts.
It is a
It's on.
microbiological
It's on.
investigation.
So,
Okay.
It is
if
a
you
mic-
have to argue it, mate. Okay.
Moving on. Now let's move on to bloods. What blood tests do we want to order? And what did I say was the most important thing to look for on bloods?
Lactate.
Yeah, boom. Do you know what the actual like blood order is to look at a lactate?
Serum lactate.
Yeah, but like, it's part of a wider test.
VBG.
VBG. Jay's going to come swooping in and save you at every turn of the corner.
I'll do it ABG, but that's just me.
And that's not ballsy, is it?
Yeah, ABG. So.
Okay, so VBG, and now I'll open the floor to whatever you kind of... Right. And specifically, you want to take blood cultures from 2 different sites.
It's simple. Full blood count.
Yeah, well, keep going. Roll off the whole trifecta.
Full blood count. CRP, LFT, US, UEC.
It's going to say
Great.
USA.
Yeah.
And if you're worried that they might have DIC,
Grip and hold.
Coag.
yep, amazing. And we like to just throw in BGL in there as well.
BGL.
BSL.
That's a bedside. That I can't
Yeah.
tell.
But it's in bloods
bedside.
though.
Yeah.
I know, but it's more. It's a bedside
Okay.
bloods.
Imaging, what might we consider?
Chest X-ray.
Yeah,
Exactly.
You're welcome to the hospital chest X-ray. Yeah.
Here's your daily dose.
Yeah, daily dose.
Cool. And some miscellaneous imaging that you might do, say, for...
If you believe it, maybe an abdominal infection, you may do an abdo CT.
Beautiful.
For any collections.
What might you do at the bedside before you did an abdo CT?
We just
'Cause-
fucking went through the bed.
But
What?
the radiologist's like, I'm not putting radiation to this
MRI
person.
at the bedside.
You can use sound waves, man.
Oh, ultrasound.
Exactly. And yeah,
Yeah.
CT. That's really well done, guys. So
What was it really?
it was really well done. Yeah, you got all the things on my list. Screen.
Actually,
which
I
is
actually remember
involved.
one bedside one you could do. COVID PCR.
Oh my god,
Damn,
I
see.
didn't include that.
'Cause I
but-
risk stratify. I care about bed management. You know, if they,
Why are you looking at me when you say?
Okay. Moving on. Included in that was your septic screen, which we already mentioned, including the urine MCS, the lumbar puncture, blood cultures, and chest X-ray. Moving on to management of sepsis, and another first principle, and that being time is critical in sepsis management. And there's something that we love called the golden hour, where if a patient has suspected or confirmed sepsis, you have to start antimicrobial therapy within 1 hour, or bad things happen.
Regardless of the cause of the sepsis.
Yep. Now, has anyone heard of the Sepsis 6?
a lot of acronyms in this.
I can't help it. I'm a very simple person. I'm very simple-minded.
I was actually asked this by an RMO in ED.
If that's the case, do you want to run us through?
Oh, I can't remember it, but
Well, I guess you were freaking paying attention there.
So you do, I think it's fluids,
Yep.
antibiotics.
Great.
You do a VPG for
Yep, maybe.
blood cultures.
That's definitely is.
Come on, Jason, you're the smart one here.
Hey, I didn't say that. I got
Well, let's just think back. Like, what are the main pathological processes happening? We know.
So you're correcting hypovolemic, so fluids is done, antibiotics is done.
Anticoagulation.
If they've got DIC, but that's not part of the Sepsis 6, but I like your thinking. If you're doing a VBG and you're checking their lactate, you're thinking they've got anaerobic they're going through anaerobic metabolism, which means that they've got...
Oxygen.
Yep. boom. So you replace the oxygen. And the sixth thing that you do...
Patient education. And just say holistic.
Patient education.
Obtunded on the
Yeah,
bed.
got to tell little Tommy with
Here's a
sepsis,
pamphlet.
No more playing in the dirt, okay? No more scratching your leg.
Non-pharmacological management.
And the sixth thing is you want to monitor their fluid status. So you want to measure their urine output, as well as reassess their vital signs and continually reassess them.
So, sepsis 6, blood cultures, lactate, oxygen, fluids, antimicrobials, and measure urine output.
That was spot on.
Nice.
Very well done. So is there anything I can add about those sepsis 6? Like we mentioned earlier, when you're taking blood cultures, you want to take them from 2 separate sites because this reduces, the effect of potential contamination. And something else, you want to take this blood culture before you do what?
Give antibiotics.
Good, because we like high yield blood cultures. Monitor their lactate, because really high lactate is associated with poor outcomes. You want to give them O2 therapy. Do you have any idea what we might aim for in your average Joe Blow? What their O2 sats, what we want them to sit around?
Above 96.
Must be nice.
92, 96?
94.
92.
Sure. 95 to
Okay.
98.
Wait, so it's 95, okay.
95 to 98 in the guidelines that I have.
That's-
And then we want to give them IV fluids, and that's for a few reasons. A, it's going to increase your cardiac output, which if you have hypoperfusion of your vessels, it's going to improve the oxygenation of your fluids, irregardless of whether you've got hypoxemia, right? Any guesses at what fluids you might want to give?
Saline?
Yep. You want to give normal saline at 30 mils per kilo, and you want to give it in boluses rather than an infusion, because you want to, aggressively try and restore hemodynamic stability.
Mm.
Lastly, you want to monitor their urine output. And how might we do that?
Catheter and fluid balance chart.
I couldn't have said it better myself.
Okay. What's minimum urine output?
That's my next question.
0.5 mils per kilogram per hour.
Oh my God.
My man.
Jeez
Yeah.
Louise. And now let's talk about antibiotics last, because they're
No
kind
one
of...
likes them.
Yeah, no, right. So going off ETG, we're looking at the guidelines for community-acquired sepsis of unknown origin, because this is the most common presentation of a septic patient. And the antibiotics you want to give in that case is gentamicin IV, flucoxacillin IV. If they're in septic shock, you want to add vancomycin to those two. And if you have a high degree of suspicion they've got Neisseria meningitidis infection, which would be things like the non-blanching rash, neck stiffness, photophobia, you also want to give them a healthy dose of IV ceftriaxone, because why not?
Right, so gentamicin, flucoxacillin, vancomycin,
Mm-hmm.
and ceftriaxone if you think there's a risk of meningitis.
So the main two would be gent and fluclox. If they're really unwell, you add vanc. And if you think they have Neisseria meningitidis infection, you add cef.
Yeah, I think in the OSCE, I'm just going to say refer to guidelines.
Yep. Well, we go above and beyond at 1 p.m. So you do you.
Yeah.
So that's the sepsis 6. I'm just quickly going to touch on the complications of sepsis. So one that we've already discussed is DIC. Another one that we've already discussed is hypotension. And if you have really severe hypotension associated with tachycardia and your tissues aren't meeting the metabolic requirements, what's that state called?
Shock.
Shock, exactly. Yeah, septic. And then DIC, sepsis, septic shock can cause organ dysfunction and organ failure. And if you have a bunch of organs going crook at the same time, it's called a syndrome called multiple organ dysfunction syndrome. And does anyone want to take a stab at what the mortality rate of a septic patient with MODS is?
95%.
Okay, well, okay. Let's just reel it in. Just
We
reel
do
it
have
in.
antibiotics, you know, like, geez.
Reel it in. But I like the enthusiasm. It's bad.
33%.
33%.
Mhm.
I love the specific nature to that answer.
63%.
No.
35%.
35. Nian is our winner. It's at least 25%, so I reckon 33 is closest.
Nice.
But
Yeah,
still,
well,
you know,
well,
one in...
mathematically it is the smallest difference. So
What else would it be?
what other?
Okay, Jason.
Yeah.
But still, that's 1 in 4 patient. 1 in 4 patients.
Yes.
That's still 1 in 4 patients that are, you know, getting this and dying, which is really tough.
Yeah, so 25 out of 100 is 1 quarter. Okay. Case.
I had to mentally do that on my
Yeah.
mental chalkboard just
Yeah,
very
mental
quickly to
chalkboard,
confirm. Okay. All right, and yeah, that's it, guys. So there are 3 key takeaways from this session today. Firstly, sepsis is a syndrome caused by the immune system's response to an infection, and it's characterized by those pathological processes that we described, that being hypotension, widespread edema, hypoxemia, and end organ dysfunction. Secondly, no organ system is protected from the consequences of sepsis. So because of that, it's very important that we investigate widely and we treat very soon. And that leads us into our 3rd key takeaway, and that is when managing sepsis, we have to try to implement the sepsis 6 within that period of time called the ...
Golden hour.
Golden hour. Everybody
Together.
Exactly. So that's everything. All right, everyone. So that wraps up our talk on sepsis. Thank you guys for joining me today. I think that was really good. You guys did really well. As always, you can check out more 1PM content on our streaming services, and you can check out our website and socials for more information. And for all your first principles, keep it right here at 1PM.
And that is incredibly lame. Jesus.
Yes.
I think I just died of